Good morning, everyone. We are pleased and honored today to have with us representatives from Population Council, an IATT partner, and EGPAF, the Elizabeth Glaser Pediatric AIDS Foundation, another IATT partner, to present a multi-country PMTCT Cascade analysis that was conducted as part of the USAID-funded HIV Core Project. And as you know, this presentation and the results of this study has a lot of implications, particularly as many countries are scaling up the implementation of option B+, and retention monitoring is a huge challenge, and keeping mothers and children in care until final infant diagnosis and final confirmation of diagnosis is determined. And so I think the methodology and results of this study are very timely and very important in terms of PMTCT programming and achieving elimination of mother-to-child transmission of HIV. And we are pleased to have with us two presenters today. I will introduce them jointly. The first is Sam Kalibala from Population Council. He is the director of the HIV Core Project, and he brings with him many years of experience in HIV research and monitoring and evaluation. We also have with us today Gottfried Wolk of EGPAF, and he leads the technical and management for the global implementation research activities of EGPAF, and he represents the Foundation as one of HIV Core Project's technical advisors and leads 3 operations research studies related to PMTCT. And prior to joining the Foundation, he served as a senior research epidemiologist with RTI, and also was a PI for the National Institute of Health funded IDEA project for Central Africa. He also previously served for 20 years at the University of Zimbabwe Medical School as a professor of epidemiology and chair of the Department of Community Medicine. So I'm pleased to introduce both of these speakers today. Sam Kalibala will present an overview of the research, and Gottfried Wolk will go more in detail around the methodology and the results, with a particular focus on Rwanda. So for the initial part of the presentation, we will listen to the speakers for about 20 to 30 minutes. The presentation will take place, and then after that we will have a Q&A. Feel free to type in your questions and answers as your questions as they arise, and we will keep track of them, and we will return to them during the Q&A after the presentation. Feel free to also let us know if you're having any issues, and we'll respond to you by typing in. Without any further ado, we are pleased to introduce Sam Kalibala, who will provide a summary and overview, and then turn it over to Gottfried Wolk of EGPAF. Thank you very much for being with us today.
Yeah, thank you very much, Jessica. And I want to say thank you to everybody who is attending. I am the task order director for HIPCOA, which is the task order funded by USAID, aimed to improve efficiency, effectiveness, scale and quality of HIV treatment and PMTCT programs. And we work by conducting operations research, program evaluation. We focus on promoting use of these findings from this research, and we also focus on building local capacity of in-country partners to design and conduct operations research. The 5-year project ending September 2016, and we have 19 studies. We are a consortium led by my organization, Population Council, and we have partners, 3 partners: Elizabeth Pediatric AIDS Foundation, Palladium, which was formerly Teachers Group, and the University of Washington in Seattle. I just want to briefly summarize our contribution in the PMTCT area. First of all, in enhancing PMTCT program effectiveness, we work by identifying gaps and successes in retention and adherence of mother-baby pairs. For example, we are working in Cote d'Ivoire to identify reasons for delay and lost follow-up at each step of the PMTCT cascade. We are also engaged in evaluation, program evaluation. And this one, for example, is doing it in Zambia, where we participate under the chairmanship of Dr. Kankasa to evaluate the national PMTCT program. Then we also conduct the operations research to test new approaches for improving PMTCT program. For example, we are testing M-Health and transport reimbursement approaches for improving mother-baby pairs retention in Tanzania. So with that introduction, permit me to hand over to my colleague Godfrey, who is now going to go in depth into the study.
Thank you very much, Sam. This is Godfrey Wilk. Welcome, everybody, and good day. So I'm going to go into the introduction to the study that we did. And as we all know, there is global consensus that transmission of HIV from mother to child can be eliminated. The Global Task Team, co-chaired by UNAIDS and the U.S. Office of the Global AIDS Coordinator, OGAC, has developed a global framework with the goal of eliminating new infections among children, defined as a transmission rate of less than 5% by 2015. Countries most affected by mother-to-child transmission of HIV have adopted this goal, yet reaching the goal depends on the optimal execution of each step in a complex cascade of activities, including retaining pregnant and breastfeeding women in the PMTCT program. Retaining these women is a critical element in the cascade, as it is a measure of program adherence, which is necessary in turn for drug adherence, education, and psychosocial support. However, there are barriers to the retention of women in the PMTCT program. In low and middle income countries, only 62% of pregnant women were receiving the most effective regimens for PMTCT in 2012. There is a paucity of knowledge even about the extent of retention in care, some of it due to challenges in effectively monitoring who is retained or not. To better understand this situation, we carried out a secondary analysis of patient-level data extracted from registers in selected countries to assess the extent of and factors associated with retention among women and infants in the PMTCT program. We used the case study approach where we selected 4 countries. At the time of the study, Kenya and Swaziland were implementing the option A guidelines, Rwanda was implementing the option B guidelines, and Malawi was implementing the option B plus guidelines. Rwanda was selected because it had implemented the option B guidelines for over 2 years and was regarded as a model country for HIV programming. Though Malawi had only recently fully implemented option B guidelines in January 2012, it was the only country at that time that was currently rolling out this program. With the emphasis on and support for option B+, and with many countries adopting this option or piloting it, it was of critical importance to understand how these new guidelines may impact retention. Kenya had been chosen as an option A country, as it is a large country with variable rates of HIV prevalence, and because it has a mature program, having implemented the guidelines since July 2010. Swaziland was chosen as another option A country, as it is a small country, also with a mature program. The guidelines were adopted in July 2010 with fast implementation. It is also a country that is reported to have reached 90% coverage of prevention of mother-to-child transmission with antiretroviral therapy regimens, and is projected to meet the 2015 targets of virtual elimination of new child HIV infections, if the 30% decline from 2009 to 2011 is sustained. A central criterion for the selection of countries, except for Malawi, was that their programs were mature enough to enable a 12-month post-delivery retrospective analysis so that retention could be assessed over much of the PMTCT cascade, including breastfeeding. For this presentation, we focus only on the Rwanda findings. We selected Rwanda for this presentation because it illustrates best some of the major issues in retention. In addition, because of the timing of our study, we only had 9 months of post-delivery follow-up, not 12 in Malawi, which, as we all know, is option B plus country. So we developed the following research questions. Our primary research question was, what are the levels of and factors related to retention among women and infants in PMTCT care in purposefully selected countries? And in this analysis, retention was measured by the rates of program, i.e. clinic attendance, as documented in the health facility registers. So specifically, what are the levels of retention 30 days after entry into the PMTCT program, at delivery, 6 weeks, 2 months, 3 months, 6 and 12 months post-delivery, and how do the levels of retention vary by demographic and clinical characteristics among women and infants? How do the levels of retention vary by facility characteristics? And what are the program characteristics associated with retention? So, for our methodology, we constructed a retrospective cohort of HIV-positive pregnant women and infants using the antenatal care, PMTCT, labor and delivery, child welfare clinic, postnatal care, and early infant diagnosis registers, as well as pharmacy and follow-up records. We analyzed data for women enrolled in PMTCT and for their HIV-exposed infants. Over the time period October 2010 to March 2012, from ANC labor, from all the charts that I've mentioned already. We also conducted key informant interviews with the staff in charge of selected facilities to obtain health facility data. We sampled from Elizabeth Glaser Pediatric AIDS Foundation supported sites to collect these data. And in all countries except for Swaziland, sites were purposefully stratified by type of facility. So urban and rural, hospital, health center, and so on. The selection was also guided by logistical concerns. Sites were stratified based on the difficulty of travel to them and the cost, as well as the number of HIV positive cases. For example, if a site had only 10 HIV positive pregnant women in a year and involved extensive and expensive travel, it would not be selected. Also, if a site was known to have poorly maintained records, it was excluded. Because as we mentioned earlier, this was a retrospective study. We depended very much on the records and the registers. In some of these countries, test kit stockouts are highly common, and it was important to include sites that had a more regular supply of test kits to ensure the sample size was reached. So, as I mentioned, we're focusing on Rwanda in this study. And in Rwanda, we sampled 5 sites, 2 urban and 3 rural. All of these sites had a minimum of 40 HIV positive pregnant women per site per year. We considered stratification of location and type of facility, so a mix of hospital and health centers. And so, given this criteria, our proposed sample size was 474 HIV positive pregnant women, which we sampled from the 5 facilities, in proportion to the expected number of women who were HIV positive at ANC at the time. Based on knowledge of retention levels in Rwanda and the existence of patient files, we expected 30% of the women to attend the 12-month visit. So data were extracted on all HIV positive pregnant women who registered, so all of those who were selected, who registered at these facilities during the time that option B+ was implemented. And we also interviewed up to 10 facility in charges, at least one facility, one per facility. So I'm going to talk now about how we derived our endpoint. So retention was estimated from the registration date to the end of the study. And this period was divided up into 6 non-overlapping time segments. So 30 days after registration, at the delivery date, at 6 weeks, at 3 months, at 6 months, and at 12 months. And these were not exact periods. We allowed about a 2-week overlap period between this time to allow the women to come back. For each time interval, if there was an indication, so for each time interval, a mother or child received 1 if there was an indication that she made at least 1 visit to a health center or facility, and 0 otherwise. For the retention 30 days after registration, for the registration date, we investigated the first drug receipt date. If the date was at 30 days or within 2 weeks after the 30 days, that mother was considered to be retained. For retention at delivery, we used all possible record indications that delivery had occurred: place of delivery, date of delivery, where available, child date of birth if available. And if any of these were available, we concluded that the mother was retained at delivery. Retention after delivery. At 2 to 4 months, 5 to 7 months, and 11 to 13 months, any indication of ART receipt during these periods. And we analyzed infants and mothers separately. For the retention of the mother, the count outcome indicated how many visits were accomplished out of a maximum of 6 visits that they were expected to attend. If a mother made more than 1 visit during a given time period, this indicated that she was retained. We did not count multiple visits during the same time period. So, the analysis. We conducted bivariate and multivariate analyses using generalized estimating equations, GEE, to determine factors associated with retention. For mothers' retention, visits 1 and 2 have the total of those who were registered, total number of those who registered as the denominator. The remaining visits have the number of those who made it to visit 2, those who delivered, as the denominator. So let me go on to talk about the findings. When we looked at, first we looked at the proposed versus the expected sample size versus the actual sample size. And overall, we obtained 96% of our proposed sample size, with a slight deficit at one of the rural sites. One urban site contributed 45% of the records reviewed, and one of the 3 rural sites contributed 24%. As concerns the background characteristics of the women sampled, in the records reviewed, the mean age of the women was 28.6 years, with a mean parity of 2.6. Over 85% were recorded as married or living as married, and only 12% had secondary education. About half were recorded as farmers, and about 30% were housewives. However, there was no information on referral for ART initiation for over half the women. Only 18% were recorded as having had the recommended 4 or more ANC visits for this pregnancy. Nearly 60% were known to be HIV positive at the first ANC visit, and nearly 75% of the women had a CD4 count test result. Of the cases with recorded WHO staging, 96% were WHO stage 1 or 2 at baseline. Information was available on ART for 364 women, about 80%. Among these women, 78% were recorded to be on tenofovir containing regimens, and 15% on AZT containing regimens. Concerning the characteristics of the infants, many of the reconstructed infant records were missing critical information, including place of delivery, 37%, as well as mode of delivery, administration of infant PCR, dispensing of cotrimoxazole, and infant feeding practices. The description of the health facilities, and there were 5 initially. So all 5 sampled health facilities were health centers. With one owned by a religious organization and the remainder government-run public facilities. The number of first visit ANC clients ranged from 880 to 2,200, and the number of HIV positive pregnant women, 31 to 156. Deliveries ranged from about 400 to just over 1,000. The ratio of HIV-trained nurses to HIV pregnant women ranged from 1 to 3 to 1 to 16, and one facility had 12 doctor visits in the past quarter. The maximum CD4 turnaround time was 14 days. Only one facility had a vacancy, and all facilities indicated that they had active follow-up mechanisms, with the follow-up starting within a week in 3 facilities and after more than a week in 2 facilities. One facility experienced stockouts in the past 3 months, and 4 facilities provided both adult and pediatric ART services. All facilities provided ART refill and follow-up for PMTCT services. Now, what was the retention at the various time periods? For the women, about half of the women returned at 30 days. About half of the women returned at 30 days, but at 12 months after entry into the PMTCT program, 67% of the women, so nearly 70% of the women, were retained. For the infants, only 40% of them returned at 6 weeks, but by 2 to 4 months, about 90% were retained, and about 80% were retained at 12 months. When we looked at demographic and clinical characteristics in relation to retention, starting with marital status, we found that compared to married women, women who reported that they were living as married had higher retention levels in all specified time periods, except at delivery, with 64% retained at 12 months, compared to 39% among the married women. Analysis of retention by employment status showed similar retention levels among housewife and other employment status, but significant differences between these groups and farmer. Examination of retention by whether women were referred to an ART initiating site showed that, with the exception of delivery, women who had not referred had much higher levels of retention compared to women who were referred. We then did a multivariate analysis with all the other factors in the model to look at what were the facility factors that were associated with retention among women. And this is shown in this slide. And in this analysis, only the variables that you see in the model remain significant. And these were rural facility location. So women who attended a rural facility were almost 30 times more likely to be retained compared to women who were in an urban facility. We also found an association between the number of ANC clients and doctor visits, and these were negatively associated, so that ANC clients and doctor visits were inversely related to retention. Women who retained were in facilities, were from facilities where there tended to be less clients and less doctor visits, whereas facilities which had higher deliveries, women in those facilities tended to be more positively associated or better retained in those facilities. So in summary, we found that about 70% of women were retained at 12 months postpartum. About 76% of infants were retained at 12 months of age. And we found that facility location, rural, and number of deliveries were positively associated, and ANC clients and doctor visits were inversely associated. The 67% or 70% retention was similar actually to what was reported by the Rwanda Ministry of Health at the time. The retention improved after delivery. Many women may deliver elsewhere, and certainly this has implications for tracking and tracing of these women because they go somewhere else to deliver their infants. And this may be because the services may be better at these other facilities, or they may want to deliver near their homes, near their mothers. And so we also found better retention in rural areas, and this may be because there may be greater mobility in urban areas. The inverse association with antenatal clients and doctor visits may be because that but positive association with number of deliveries suggests an association with facilities that may be larger and more comprehensive, where women come to deliver from other areas. And this finding is supported by the fact that we found retention was associated with fewer doctor visits, perhaps because those sites that had less doctor visits may have already had adequate number of doctors that were stationed there. Some sites may have more doctor visits where there is insufficient staff and doctors, and these sites may tend to be smaller. The negative association of ANC clients may be an indication that lower workload is associated with better retention. And indeed, a South African study found that higher clinic patient loads were associated with higher loss to follow-up of ART patients. Now, this study we obviously were limited by the small number of sites that we did, but these sites probably had the best records and data that were available. In addition, it was problematic that there was a lot of missing data, and certainly this indicates an underlying problem, not only in the Rwanda setting that we did, but in fact in the other countries that we also studied, of the adequacy of records, and thus our ability to adequately assess retention. Nevertheless, the data suggests that facility characteristics are important in retaining women and infants in the PMTCT program. And in fact, when reviewing findings overall, including from the other countries in the study, we found that rural location, workload, ownership of the facility, provision of comprehensive services, active follow-up, and the availability of doctors may be positively associated with retention. So I'd like to acknowledge the following, the following co-investigators who you see on the slide, and as well as the Population Council, our partner in this, and the USAID who funded the study. Thank you.
Thank you very much, Godfrey, for the insightful presentation. I'll provide a very brief recap of what was discussed, and then we'll move on to the Q&A. And I'd encourage all of our participants to send in your questions or comments as we summarize what has been discussed. And once again, thank you very much for the summary of the findings from the multi-country PMTCT Cascade analysis that was conducted in Rwanda, Kenya, Malawi, and Swaziland, really looking at different endpoints to measure retention and across different settings where the implementation of WHO guidelines varied, including the implementation of option A in some countries, option B in Rwanda, and option B plus in Malawi. Some of the findings to highlight were that marital status, being married, was associated with retention, as well as a rural health facility was also associated with higher rates of retention, and perhaps what was very interesting was the explanation for the inverse relationship between retention and the number of ANC clients and doctor's visits being linked to the fact that maybe lower workloads were associated with better retention. And perhaps we can go on to discuss for what that means in terms of also health system strengthening, and particularly as we look forward to the implementation of option B plus. Of course, it was acknowledged that one of the study's limitation was the small number of sites that were included in the study, as well as missing data, and I think that's also reflective of a lot of the more broader discussions that we as a global community are having around how to improve data systems. And I think that discussion and dialogue is gaining traction and steam, and particularly there are a number of meetings coming up where that will be discussed at more length. And I think overall the study really shows that there are key characteristics of health facilities that are very important and correlated with better retention. So perhaps we can frame the discussion around those characteristics and how to ensure that health facilities are better able to implement these interventions so that retention is improved. I think some of the questions might have been addressed by the last few slides, but we will review them anyway. I think one of the questions was around the measurement of retention, and so Lori Bollinger asks, to facilitate comparison with other results in the literature, can the authors also comment on the second retention rate, for example, after 2 months, in the traditional, more conventional way, with the denominator being the number registered? Gottfried, yeah, and
let me go back to
Lori,
the slide.
yeah, okay, sure. Do you have it, Gottfried, or do you want me to go back to the slide? If you can.
It's going very slowly, but
Okay.
okay. Is this the one, retention after delivery?
She didn't refer to a slide, but I'm not sure. Lori, perhaps you can type in and say what slide you're commenting on. The original definition of retention. So it's going back, I think. Here.
This one?
Yes.
Okay, so we were we estimated retention from the registration date. So where we had information that the mother had registered at the beginning to right at the end. And this was divided up into these segments, overlapping segments. As you can see in this schematic. And so we then looked at these time periods of from registration to 30 days after registration, then at delivery, and then 6 weeks after delivery, 3 months, and so on.
Okay, Lori, does that answer your question? And if not, can you maybe type in a more specific question? And we'll come back to you. There was another just quick clarification around, is that OR 29 or 2.9? So I think that was in one of the other slides.
Yes, it was 29.
Okay, great. So thank you for clarifying that. Then a second question is around what were the elements or modes of active follow-up in Rwanda? Did it include initiatives led by peer outreach workers or mother support groups? Could you talk a little bit more in depth about what the active follow-up really means or look like in Rwanda?
As far as I'm aware, in terms of the active follow-up, and remember this was a retrospective, this was through interview with the health facility in charges. It was community health workers going out and following up on the mothers.
Okay, so it was community health workers conducting home visits. Once a mother was determined to be lost to follow up, is that correct?
Yes.
Okay.
Yes.
And so that was the main mode of active follow-up. Were there any other, do you know of any other support groups or any other methods that were implemented?
No, I don't think, no.
Okay. So a follow-up question. I think there's another question that's similar to that. So I will skip over that question because I think it's similar to what we just asked. So the second one is, did you follow up women lost if they are picking up their ARVs in other close by facilities? So perhaps they didn't come back to their original facility where they were supposed to attend a visit, but they picked up their ARVs in another facility, or maybe this gets at the transfers or that might be occurring as well between facilities.
No, we had no way of knowing that. We did not, because remember this was a records review, so we had no way of actually knowing that.
Right. Okay. Thank you. A second question related to the community types of community-based support question is, do you know if family-based care, or can you speak to the fact that perhaps family-based care was also considered as a factor that was positively related to retention? Of course, the study didn't measure that or identify that as available, but was there any other indication that a family-based care model had an effect on retention?
No, we were not able to look at that.
And does the study, can you explain the difference in retention between the mother and infant at 12 months? I think there was a slide regarding that. Perhaps we can go back to it. I think it's this slide 18. Perhaps maybe just reviewing and going a bit more in detail about the difference in retention. And I think the fact that among mothers it was 67% retained 12 months postpartum, and for infants 76% at 12 months of age. Why the difference?
We can only speculate why that difference might be. that it's probably because many of the, well, first of all, there's a function of the quality of the records, of the data that was available. And secondly, we can only speculate that there's perhaps greater attention paid to the infants, but again, that there's greater attention paid to the infants.
Greater attention paid to the infants by healthcare providers?
By the family, by the
By the
family.
family.
Because,
Okay.
yeah, because remember, we analyze the infants separately.
Mm-hmm. Okay. What would be the recommendation of the study as to when to ultimately measure retention, since there were multiple points at which retention in the study was measured?
That actually, that as you know, as you all know, that's a huge debate, because because people come in and out of the system, and if somebody hasn't been, somebody who goes away for 6 weeks, 2 months, or many months and then comes back again, do you consider them to be retained, is always an issue. So I think as we are moving more and more to option B plus, we really want to be able to measure retention over a longer period of time. So what is perhaps more and more important is looking at retention 12 months and 18 months and 24 months, in fact, post-delivery, if we could do that. But I would want to suggest that the longer period, so the 9, the 12 months going out, would be more important to do.
Okay, thank you. And I think it also, the question gets at the fact that a lot of times, disengagement and re-engagement in care seems to be quite common, and again, a lot of these studies that are being conducted will help inform what the formal definition of retention is, and of course it does also vary country by country in terms of national guidelines, but I think a lot of the studies and research that are coming out from different contexts will help to inform when is the best point to measure retention, and perhaps it is along different time points as well. So I think there's ongoing discussion about that, and it's a very, very good question. Another small, I think, question of clarification on the OR. It says the 95% confidence interval for that OR seems to be 2.0 to 4.0. Is that correct? I guess that question is that correct? I'm not sure it's complete. It's in reference to the earlier question around the clarification about the OR, whether it was 29 or 2.9.
Oh yes,
Yeah.
sorry. Yes, there's there's an error on that. Yes.
Okay. Yeah. Okay. So yes, there's a slight error. So thank you, Harriet, for noting that, and we'll correct it before we share the slides. In the so this is a new question. In the demographic slides, I believe you said 60% of women had known their HIV status at their first ANC visit. Is there a difference in retention between women who already knew their status compared to women who were newly diagnosed as HIV positive at their first ANC visit?
That was a good question, and we didn't actually end up looking at that.
Okay. So no, Elizabeth, we weren't. The study leads and the team did not look at the difference between those who knew their status and women who were newly diagnosed as HIV positive. Again, there's another question about any difference in terms of age and a comparison between young mothers or older mothers. It doesn't seem like you looked at that as a variable, but in case you did, I'd ask the question. Was there any difference in age and retention?
No, we did not find a difference.
And any indication as to why the retention rate is lower at the early stage of follow-up rather than later stages? Again, that might be speculation, but
Yes,
any
again,
indication?
it's just speculation because, as I said, it's a records review,
Hmm.
and we I can only assume that women sort of went somewhere else and eventually came back um, later on. But other than that, we have no information.
Okay. And I think there is also some other studies and research in the literature that gives some indication as why this might be. Um, in terms of obviously this study doesn't speak to it, but other studies speak to perhaps needing time to process the diagnosis and disclosure to family and other community members who might be of support. So there are a wide range of reasons why there might be some loss to follow up in the early stages rather than later stages. Also in option B plus, perhaps not feeling not feeling ill and therefore less inclined to take medication right away. So there are different reasons in the literature, and we're happy to share some of those resources, and we continue to do so via the IATT if you're interested in that information. So a couple of more questions, and then we'll wrap up in about 10 minutes. How did you define the cohort? In your analysis, did you use mother and baby paired register, maybe mother and baby pair registers that were linked, or a separate register for each, separate register for mothers and a separate for infants?
Um, for the Rwanda study, um, we the fortunate thing is that they had patient files. So, in a sense, they were linked data, though we still looked at the other available registers that were there, but they had patient files and often put the infant's information together with the mother's.
Okay, great. So there were separate registers, but the mother and infant information was combined on the patient files.
They had a patient file, yeah.
Yeah. Okay. And another question around the relationship between marital status and retention. Any thoughts on why married women showed higher rates of retention? Is it because of couple support, or perhaps is it a surrogate for income, having higher income?
Um, we tried to get an explanation for this, and of course we had no means of assessing income from the records. And in fact, it was the women that were living as married that weren't officially married, and there were that had better retention than the ones that had officially married. Now, it seems that some of the explanation may be that being married involved costs and registration and so on and so forth, and that may have been a particular subset of women that defined themselves as married. But again, we only can go as to what was in the records.
Mm-hmm. Okay, thank you. I think we have a few other questions. Some of them are repeated, so I won't review them. But one question that I did have is any lessons learned, especially looking back in terms of conducting the study and implementing the study, particularly for countries that might want to do something similar? Any lessons learned from how you conducted the study, what you might be do differently so that countries who might want to replicate it can learn from what was done in this multi-country study, and especially in
Yes,
regards to missing data and how you were able to work around that.
Yes, and thank you for that question. I would say one of the lessons learned is that doing a retrospective records review is extraordinarily difficult because of the whole missing data issue and so on, and that it's very problematic. And that if one is going to do such a study, it is much better to do it prospectively. If that, i.e., you need to set it up so that you will try and ensure that the data you're interested in will be collected in the records. That I would strongly advise anybody who wants to do something similar to do it prospectively. And that means some degree of investment in ensuring the variables that you are interested in, you will have data on. You'll set that up. So it means investment in ensuring in some data quality interventions and so on and so forth to make sure you get what you want.
Okay, great. And in follow-up to that, I know with the scale up of lifelong ART for pregnant and breastfeeding women across many different countries and settings, there is a lot of discussion and investment on how to strengthen monitoring evaluation systems. So would you have any recommendations for what are some key interventions to strengthen M&E systems to ensure that retention is better monitored and ultimately to improve retention?
Yes, I think one of the things, first of all, I think there's a lot of data that we collect which is probably not useful and not usable. So there's the burden on the individuals collecting the data, and so considerations need to be thought through to what do we really need to be able to better monitor retention, first of all. Secondly, I think in the bigger sites, in the bigger facilities, consideration should be given, well, for having a patient file which links mother and baby together. So some places have clipped together the cards so that you can have the mother-baby pair, because often it's separate and then it's very hard to link them. And in the bigger sites, there's a movement towards having an electronic patient record system in the bigger sites, and I think that's a positive move. Obviously, that's not going to be possible in all the sites, but I think that is one suggestion. And for monitoring and evaluation purposes, the possibility of having a sentinel surveillance system, in other words, having selected sites where you put investments to make sure you're collecting good quality data, should be seriously considered to be able to adequately monitor and evaluate retention particularly. So those are the points that I would suggest.
Okay, great. So I think in summary, you're suggesting in the future, if for a country who wants to conduct a similar study, to do it prospectively and not retrospectively, to follow outcomes, and also in terms of strengthening monitoring and evaluation systems, really to examine the data burden that is placed on healthcare providers and facilities in collecting data. So perhaps maybe streamlining and standardizing more the data that's collected, linking mother-infant pairs in the registers, establishing electronic patient record systems where possible, particularly in larger health facilities, and setting up sentinel surveillance systems to better monitor retention. And I think it seems like the study is also pointing to the importance of having active follow-up and perhaps really having strong systems, whether it's community healthcare workers or peer outreach or some type of community support system to actively follow up mothers and infants who are lost, to follow up. And I guess linked to that, I wonder, did you see any patterns that were linked to preemptively preventing loss to follow up? Or was there anything particularly that implemented in Rwanda, you know?
Excuse me, not that I'm aware
Okay.
of. Yeah.
Okay. So any last comments from our audience, from Sam? Any questions, comments? We are happy to share any resources. I'm sure the team from EGPAF and Pop Council and the HIV Core Project would be happy to share any other resources. And we will be sure to circulate other research from the literature around retention. There seems to be quite a bit of interest around that, and we have done so in the past. So feel free to look at our website and join our listserv if you want to receive this information in the future. So if there's no more questions or comments, I want to thank you, Godfrey and Sam, for being with us today, for giving us a very dynamic and insightful presentation.
Sorry,
And I turn it
Jessica.
over, to you for
Sorry,
any last
Sam.
comments.
Yeah,
Yeah,
Sam has a last
sure,
comment.
sure.
Yeah. So my comment is that we should seriously look at the number of registers that we have caused our colleagues in the field to have on their desk. Namely, the midwife in the ANC clinic is really overwhelmed with so many registers. And I think that's why now the records cannot be complete. So I think we need a serious review of the registers, especially now that everything seems to be streamlined and we're not likely to be changing the WHO guidelines very soon. Since now we're giving ART for all HIV positive women, and we're probably keeping the charts in the ANC clinic and MCH unit until the baby is 18 months. So I think we need to think about streamlining all these registers. They're just too many. That's my word as an elder.
Thank you, Sam. I think your point is well taken. The point about how to better integrate registers and really reduce the burden that is placed at the facility level in terms of collecting data, I think it's an important one and will go a long way to strengthening monitoring and evaluation of PMTCT outcomes. I think that's right, and I think those discussions are definitely underway. And so we are really pleased that we were able to feature both you and Godfrey today on this presentation to discuss the results of this study, which will, I think, help inform future strengthening of M&E systems across different countries. And I think it's a great point. There was a question or request about any evaluations from Zambia, so we can continue that discussion offline with both of you, but if there's any evaluations ongoing in Zambia, we have a participant who's interested in finding out about that. Again, if there are any last comments, Gottfried or Sam?
No, thank you, Jessica,
Thank
for
you.
this opportunity.
Oh, thank you. It's our pleasure, and again, thank you both for taking the time out of your busy schedules to be here with us. And we hope we can be in contact if there's any follow-up questions from our participants. And we've shared the link to the full report on the secondary analysis of retention across the PMTCT Cascade in selected countries. We've shared the link to that report so all of you can access it and read it at length. And we look forward to seeing you all next month on our next webinar. Again, we profusely thank you, Gottfried and Sam, for your presence today. Have a good day, everyone. Bye.
Bye.